figure out the clicker. Let's see. Does this say, where's the pointer?
The pointer's at top and then forward is forward.
Okay, I see. Okay, so yes, Linda Mongero. I'm so happy to be here. This is the first time that I've ever attended this meeting, and it's been a pleasure for me to come. And I'm going to spend some time talking about cannulation strategies for ECLS, or ECMO as I always call it. And a lot of people in the industry say you can't call it ECMO. We're not allowed to say that right now. And Dr. Bartlett, I don't know if he disappeared, but ECMO and ECLS are synonymous. So you can use it either way, and it basically means the same thing. So my only disclosure I have is that some schematics in the presentation are used without permission for the sole intention of education. So some of these the pictorials are not my own. I'm going to review outflow cannula considerations, inflow cannula considerations, indications for the type of surgeries, cannulation configurations, recirculation, some pitfalls, and discuss a little bit about who should cannulate. I won't say who should not cannulate, but you'll get the gist of it as we go through it, and then some types of cannula. So to begin, of course, you know, ECMO is extremely complicated, and it is getting more complicated, especially with all the new kinds of cannulation techniques. And we always tried to keep it simple when we did ECMO and have the circuit be as streamlined as possible, less connections, no pigtails, and we'd hope that it would make it safer. And it's getting more and more complicated, and it's getting more and more cannulations for each circuit, but nonetheless, it's where it's going. These are the different modes. Just 3 months ago, there were only 6 or 7 of these, and now we continue to add to this table. If you can look at here on the left, you can see that I have the drainage and the return corresponding to arterial and venous, and we start with drainage from the venous and return to the venous as well with arterial blood. The outflow is in the inferior vena cava back to the superior vena cava. Indications for this would be simply ARDS, so respiratory therapy. VPA is right atrium outflow back to the pulmonary artery. This would be for right heart failure. For VA ECMO, we're all very familiar with this. We have right atrium to femoral artery. This would be for post-cardiotomy, cardiogenic shock, acute heart failure, regular shock, MI, myocarditis, pulmonary embolism with shock, or any cardiovascular collapse for resuscitation. And then we move to the triple cannulation techniques, which are 2 cannulas in the venous and then 1 back to the arterial. VVA, it's inferior vena cava, superior vena cava to the femoral artery. It would be for insufficient unloading or left ventricular distension, although people are adding a lot of vents to their circuits these days. Then VAV, inferior vena cava to the femoral artery and also superior vena cava, would be for respiratory failure on VA ECMO or cardiogenic shock on VV ECMO. Then we have VAPA, so it's the right atrium, the femoral artery, and an additional pulmonary artery cannula for right heart failure during VAV ECMO or lung and right heart failure on VA ECMO. Then other categories of VAV ECMO would be a dual lumen cannula with axillary artery. It's used for physical therapy and ambulation of your patient so that the cannulas aren't coming from the groin and the patient has to walk. Or a dual lumen cannula and then back to the innominate artery. It's a sport model. It would be for a bridge to transplant. Usually when you cannulate the axillary artery, you would want to use a graft in that approach as not to injure the axillary artery. Then now a lot of people are beginning to vent, and that was something that I'm asked all the time when I give presentations is how do we vent, where do we vent, how do we do it? So some of the ways right now that I'm finding are VA vents with right atrium and then the left ventricular apex back to the femoral artery, and that would be for, again, left ventricular distension. Or then now we have what we call ECPella, when you go to the cath lab and they've already put a balloon pump in and then put the Impella in and then said, okay, now we need ECMO. And we said, well, why do we need ECMO if you already have Impella? Well, because, you know, the Impella can act as a left ventricular vent. So that's called ECPella. I think it's interesting. So let's just break them down. Look at V-A ECMO. You can see, as I said, it was for pulmonary support, ARDS, bridge to recovery, pneumonia, H1N1, which is how we all got involved with this, and then primary pulmonary hypertension, bridge to transplant for patients that have cystic fibrosis, primary graft failure following lung transplantation, or post-BiVAD insertion in an RVAD centromeg. So you're already on RVAD and now the lungs fail, so you place an oxygenator into that right side. And this is usually the approach. It's hard to see the thing. So you're coming out of the femoral vein and back to the jugular. So V-A ECMO, femoral vein to right internal jugular, you should try to use, if you can, the largest venous cannula, the largest arterial cannula. And still, you will only get about 2/3 of the calculated flow. But go for the biggest cannula as possible. Also for V-A ECMO, of course, everyone knows it's very popular, the two-stage venous cannula that's used, that's really a single venous cannula. You should use this under fluoroscopy. Unless you're very, very talented at putting this in, it's hard to tell exactly where it's going. And with any dual lumen approach, you want to make sure that the inferior vena cava blood is coming. I'm sorry, I keep losing my little pointer against the white. You know, low in the inferior vena cava and then out through the circuit and oxygenated back, and make sure that it points across the tricuspid valve. And that's hard to see unless you have a transesophageal echo or fluoroscopy. So it's important to know as a surgeon really, and recommended by a perfusionist, that maybe we should do this under fluoro. And I believe most places do. But what ends up happening if it's not in the right place is that you end up with recirculation. So this is a proportion of oxygenated blood that's captured back to the ECMO circuit instead of going back to your patient. It doesn't share in patient oxygenation. And this is, you know, a difficult problem when you have it, but that's why you have to pay close attention and diagnose this so that your patient is actually getting oxygenated. A sort of new on the market is this Protect Duo. All the surgeons in the country want to use this cannula, and they won't sell it without the pump attached. It bypasses the right ventricle. It needs a competent pulmonary valve. You can do it under transesophageal echo. You guide it forward through the tricuspid valve, the right ventricle, and the pulmonary valve to the pulmonary artery. And we have had surgeons that were able to use other cannulas like Biomedicus cannulas and able to get this approach. But the Protect Duo is designed to do that. And so we're going to see more about this cannula and this system in the near future. And I think that was mentioned previously in a presentation this morning, but as it's been purchased by LivaNova. Okay, let's just take a look at the three configurations. So the Tandem Heart Protect Duo cannula is a 29 French dual lumen cannula, and you can see, as I said, that it goes through the right heart and sits in the pulmonary artery. And then also you can have an inferior approach where it comes up through the inferior vena cava and goes across through the right atrium and across into the pulmonary artery. Or you can go across the septum. So it has three very interesting various uses. And again, I think this is going to be popular going forward. We did try several times to use the Tandem Heart with an oxygenator, and it didn't have the power to give us the highest flows that we needed. But let's just look forward and see what happens. V-A ECMO, this is what a lot of perfusionists post-cardiotomy are familiar with: cardiac support, cardiopulmonary support, lung transplant, emergency cardiac arrest situations, failure of weaning from cardiopulmonary bypass, bridge to recovery for LVAD implantation, Primary graft failure, as I mentioned before, post-transplant, acute coronary syndrome with cardiogenic shock, so that's your call to the cath lab where they're resuscitating and you run there for ECMO. And then now, again, septic patients. At one time we didn't touch a septic patient, but now in vasodilatory shock, as Dr. Bartlett explained, that he thinks that it's completely worth it and should be done. It's a femoral approach here, as you can see. And the patient has now minimal cardiac function because they're stunned, the heart is stunned, so the oxygenation that's provided from the femoral approach is completely working. And one thing that you always have to make sure that you do is provide flow to the distal vessel so that the legs don't get cold when you're on VV ECMO. Now, if we look at this depiction of femoral VA ECMO with no cardiac function, so you have no output. It's a post-cardiotomy arrest ECMO. It's a bridge to recovery for post-transplant. Again, no cardiac function, no waveform on the arterial line. The blood flow is above 2.4 index or higher, and the patient is completely supported on VA ECMO. So the femoral arterial line is not a good indication of adequate perfusion to the head, so preferably always have a right radial. And post-oxygenator blood gases should be equal or similar to the radial artery. So it's safe to treat a patient's right radial blood gas with ECMO. Now, so a few days after VA ECMO support, what we hope is supposed to happen is the heart starts to come back. And as the heart function improves, you have now an arterial line waveform present, but what you end up with is two completely separate circulations. So the heart is pumping deoxygenated blood to the head, and the lower body is getting oxygenated. If for any good reason lung function isn't good, you should add another cannula, so VAV should be considered. And this is, let's see if this is going to run. How can you touch that and see? Yep. Oh, there you go. Okay, so this is showing descending aorta. This is showing how cardiac function improves. And as you can see, blood gets from the femoral approach up almost to the head vessels, but because it's competing with the heart, deoxygenated blood is going to the head. And that's a very important consideration when you're on VA ECMO. Also, VA ECMO with, it's also called a mixing cloud. It's the same depiction here. Deoxygenated blood getting this way and the oxygenated blood unable to get to the head. It's also known as Harlequin syndrome. You can Google that and read about it, but people are getting very familiar with this now. At one time it was hard to diagnose. We didn't actually understand what was happening, and I'm sure that plenty of patients did not do well because we weren't really sure of how to handle this. But anyway, in venous arterial venous ECMO, VA ECMO plus a vein, you can see now oxygenated blood gets back to the heart. And you have femoral cannulation with an internal jugular, cardiac function, but still maybe no lung function, so you stay on ECMO. You are perfusing your arch and your distal aorta. You're perfusing your head and your coronaries and your abdomen and your legs. So you're managing your patient properly. So VA ECMO for pulmonary and cardiac support, if now at some point after the cardiac recovery, the VA portion could be removed and you could stay on VV ECMO for a longer period of time if necessary. So we have patients that come for scheduled VV ECMO, but while in the OR they arrest, so they automatically add now another cannula. And it's usually not planned, but it's a good thing to do ahead of time so you don't have to go back and then operate again. Following VV ECMO, as the patient develops cardiac instability, again, when you have this kind of a situation, as you know, blood takes the path of least resistance, so make sure you place a partial occluding clamp on the internal jugular line so that you can overcome the low venous resistance, and you can just match those. VAV ECMO represented here is a mixture of both VV and VA ECMO. provides hemodynamic and respiratory support at the same time. And then a version of that, which is VV ECMO, it's a special form of VA ECMO with enhanced drainage. Hemodynamic consequences are comparable to VA cannulation. The VAV ECMO that we use with the internal jugular dual lumen cannula and the axillary artery sports model, as you can see here, I show that a graft is put on the axillary artery, but this is the sports model so the patient can actually get up and move around. This is what a patient looks like ambulating on ECMO. You saw that also on other slides this morning, but this really gives them full ability to get better. Like our ventricular assist patients, when we first put them on, they were dead to the world, but once they got their VADs and started to regain their strength a little bit, they were able to eat, and they're in a much better condition to get their transplants. So it's a really important thing to be able to ambulate. A variant of VA ECMO is V-A ECMO, if I don't have you thoroughly confused by now. But this is what's happening. It used to be just, VA ECMO or VV ECMO, and now all of these individual cannulas are being placed to help out. And I think it all makes sense, but it does make it more difficult to run the circuit. And it also can be complicated and a safety issue, because if something pulls out or something blows off, air in the circuit, end of the story. While VAV ECMO combines the features of both VV and VA ECMO, VA ECMO intends to further support the right heart failure during VAV ECMO, and the returning venous cannula is forwarded through the tricuspid valve, the right ventricle, and the pulmonary valve to the pulmonary artery. This is pretty slick. Central cannulation's our friend. This is what we do every day in cardiopulmonary bypass. If you're in the operating room and you fail to wean from bypass, total heparinization, give protamine. Usually won't start heparin in this kind of a situation for the first 24 hours. Most surgeons don't. ECMO circuit is connected to the bypass cannulation, and it's preferable to externalize the cannulas. It's not always done, but it's nice to close the chest and then wait and see whether or not the patient's going to recover, or if he has to go to ventricular assist or whatever's next. Venting of the heart, again, I said left ventricular venting, ECPALA. The Impala is used as a left ventricular vent, and it will unload the heart. Vents can come from all over the place, but just need to be careful where you place them. So superior pulmonary vein, through the mitral valve, through the right atrium, through the mitral valve, into the left ventricle, right through the apex of the left ventricle, or right through the aorta. But all come with complications if you're not careful, if they're attached to the venous limb of the circuit. So just be aware. This was a study that was done, and you can see that they used a right atrium, a left ventricle vent in the apex, and then out through the ECMO circuit and back to the aorta. And they had 12 patients in the study, and all of them were in cardiogenic shock. 3 of them were coronary artery disease with acute myocardial infarction, and 1 acute myocarditis in 6 patients. But all of these patients did well, and it's just showing you that you are able to vent, and it was a paper that was written, so I included it. So who should cannulate? So this is really controversial. This is what one of our anesthesia residents, and he said he was going to a hospital that was going to be doing a lot of ECMO. So he said, Linda, can I just come and spend some time, in the OR with the perfusion? I said, sure, absolutely, no problem. And every day, he was always digging into things. And we had a couple of cannulas that were open and not used. And I said, here, why don't you take these cannulas with you, and you can use them at your new hospital for your teaching tool when you start, developing ECMO in your unit. And that very night, he went home, and he put this on, I think Facebook it was. This is his daughter, and this is her bear, and he's doing anesthesia and putting the patient on ECMO. So I was like, oh great, now everybody knows I gave you equipment that wasn't supposed to go out of the hospital. But the point is here, cardiac surgeons are really the best at this. Everybody else is getting better, and if you do it all the time, you're probably great at it too. But the cardiac surgeon understands it the most. Or other qualified individuals, again, as I said, that have cannulated before. Serious complications can exist. When you try to cannulate a patient that has 0 blood pressure, it's very difficult. And you will find, and maybe some of you have already been through this scenario where everyone's like, oh no, it's fine, we can do it. We do it all the time, you know, and so you can help us, tell us how to do it. But it is very difficult to do. So when the blood pressure is low, again, it's difficult to find these vessels. This is an article that was written, The Pitfalls in Percutaneous ECMO Cannulation. And basically they discuss, it's an observational report talking about 720 consecutive patients receiving VV or VA ECMO from January 2009 till December 2014, so right when H1N1 hit, so they started doing a bunch of cases. So the main problems looking at some of the pitfalls were vascular complications, which completely makes sense. And basically what they said is lack of experience is the trigger of many complications. Adequate training of cannulation techniques is essential. And I totally agree with that, and I think it's a take-home message if you're gonna be starting up an ECMO program. This just breaks down the table showing that they had about 9.4% limb ischemia, difficult puncture, bleeding during cannulation, vessel perforation. It happens everywhere. Upper body hypoxia, 8.8% of the time, mild bleeding, 3.8%, and then wound infection. So we don't go without complications for ECMO. This is a picture that I took that will remain nameless. I call it 3 venous cannula JPEG. The 3 individual surgeons tried to place, and these were skilled surgeons, tried to place a cannula into a vessel, and each one of them said, oh, I'll do it, I'll do it, I'll do it, and they all ended up in the same vessel. So, I mean, these are skilled guys, so it can be very complicated. This is just to show you the distal perfusion for femoral cannulation. I think everyone knows that you need to do this, but you know, it's good to just to take a look-see to know that this needs to go down to the peripheral vessel, and an 8 or a 10 French, no smaller, because they really clot off if they're any smaller, so something good size. Finally, there are a variety of products out there. There are lots of knockoff cannulas. There's all kinds of different new companies with the cannulas. Everybody wants to be in the cannula business. They need to be thin-walled, spring-wired, reinforced, and they opened the era of percutaneous cannulation. It became the first choice now for ECMO, peripheral cannulation. The benefits are that they reduce procedure time, they decrease bleeding complications, and if with an easy decannulation, they would not need the use of a vessel repair. So that's the idea behind them. Every cannula has a flow, a pressure drop. Anybody that's in this business should be familiar with these charts and how much flow you can get and at what pressures for the cannulas. It's really important, and some people don't understand and put in too small a cannula, and then they go on ECMO and they're not doing really anything for their patient. There can be problems. It's, you know, not to scare anyone, of course, but this is a look at a fracture of a double lumen venous cannula because there was just too much torque placed on it over and over and over. And it can happen, and you need to be careful. And that's why the perfusionist needs to make rounds in the OR. They don't have to be sitting by the bedside, but they have to be paying attention when the patient's moved and things are happening. Otherwise, these kinds of things can exist. Finally, just be prepared. We had always, and many institutions have an ECMO cart set up ready to go all the time, and an ECMO supply kit that goes wherever it needs to be when they're called in the hospital. It's a really important ingredient because you don't want to be by the patient's bedside, putting somebody on ECMO and they go, oh my God, I don't have a connector. Let me run downstairs 9 floors to the pump room so I can get what I need. So everything should go with you and be there. A cart with ECMO supplies, again, in the transport bag. Almost every emergent adult, you can get a 21 venous cannula or a 17 or 19 arterial cannula, and those should be the ones of choice. It's a go-to selection that fits an average size individual. Cath lab crash, post-cardiotomy, trauma or emergency room, you can be ready in minutes. You're there, ready to go, ready to cannulate before they're even getting ready to open the patient. Finally, emergency ECMO, it is here to stay. I totally believe it. I do believe that it will be in all of the ERs, and people will be trained, and they are quickly being trained. Most, I think, is due to the cardio help and the ability of its tiny use as a full heart-lung machine. Should always have a dry setup ECMO circuit available. I mean, we have papers now that show that at least goes out to 4 weeks and is still sterile. It probably goes beyond, and others will study that, but right now it's 4 weeks. You can use Centromag, Rotoflow centrifugal pumps. You can use cardio help. You can have a sprinter cart, which has no bubble detection or pressures, which is the advantage of cardio help, but nonetheless, it still is being used. I know that McKay Getting Gay is recommending that it's not for transport, but we have transported many patients on ECMO with the Rotoflow. Crashing cannulas, again, 21, 15, 17, arterial, and again, a distal cannula. While physicians cannulating ECMO circuit is primed, we're already primed and ready to go. So the take-home message is exactly what everybody was saying this morning. ECMO is a team sport, and always be prepared. Thank you.